Hello, my name is Mary Vickerman, and I am with the State Health Insurance Assistance Program with Baltimore County Department of Aging. That is the SHIP office with Baltimore County Department of Aging. We are a great team of individuals. We help provide third-party, unbiased information about Medicare and helping people choose their best Medicare options. So we are going to talk about today specifically Medicare changes and how they are affecting caregiver services and family caregivers, again, for Baltimore County residents. So without further ado, let's go ahead and start our presentation. All right, so again, Medicare changes for caregivers and how those changes with CMS, the Centers for Medicare and Medicaid Services, are benefiting caregivers today and ongoing. All right, our agenda for the presentation, we're going to talk about common insurance terms, just to make sure that we're all on the same page with different phrases that I will use during the presentation. Medicare basics, we're going to talk about Medicare Part A and B, and specifically home health care services associated with both parts of Medicare and coverage rules. We're going to talk about that 2024 policy change and how some additions are helping caregivers. We're going to talk about programs, both federal and state, that will help reduce healthcare costs and potentially caregiver services as well. And then the last thing we're going to touch on is how to be a fraud fighter and what to be on the lookout for to prevent Medicare fraud, waste, and abuse. All right, so again, our terms here, just some important things to know as we move forward. Coinsurance is the amount that you may be required as the beneficiary to pay as your share of costs for ongoing services after you meet that deductible. For most Medicare Part B covered services, that breakdown is going to be 80% for Medicare and 20% for the beneficiary. So again, it's that percentage, that coinsurance, 20% in that example is going to be the beneficiary responsibility after they have met their deductible. The deductible being that initial amount, the first amount that you need to pay as the beneficiary before your insurance, whether that's original Medicare or Medicare Advantage plan, or maybe even your Part D plan, your Medicare drug plan, is going to help kick in for and help pay for your costs, services, prescriptions, whatever it may be. Again, the deductible is what you're meeting first as the beneficiary before your insurance will help kick in for your care. Copayment is the dollar amount, usually a fixed dollar amount that you would pay for ongoing costs of care as your share, again, as the beneficiary. You'll see it a lot with Medicare Advantage plans. Potentially, you would have a $5 copay for a certain medication or maybe a $20 copay for like a specialist office visit. Again, those are going to be fixed dollar amounts instead of a percentage like with coinsurance as your share of costs. The premium, last word, is the periodic payment that you're making to either Medicare or your insurance company. And that is just to be covered by the plan. That's you essentially like purchasing that plan. And again, it's that payment that you're making on a periodic basis. Usually I would think of it as like a monthly amount that you're paying to be covered by that plan or have that coverage. One example would of course be the Medicare Part B premium. That amount changes each year, but again, it's a dollar amount that you're paying each month to have that coverage. Any other questions on terms? You can go to the CMS glossary. I have that included here. That's, again, the Centers for Medicare and Medicaid Services glossary. There is a Medicare.gov glossary. When I was updating a lot of these slides, they had taken it down probably to make some updates themselves, but that's also another avenue that you can use to look up any other terms you have questions on. So again, we're talking about caregivers. We're talking about some recent changes to policy that directly affect caregivers with Medicare. So let's talk about how CMS defines caregivers. Again, Centers for Medicare and Medicaid Services says that a caregiver, well, we have two definitions actually, is an adult family member or other individual who has a significant relationship with and who provides a broad range of assistance to an individual with a chronic or other health condition, disability, or functional limitation. And a family member, friend, or neighbor who provides unpaid assistance to a person with a chronic illness or disabling condition. And again, some of these policy changes that they have made and other programs that they have launched as of 2024 really target improving the caregiver experience, and we will talk about that. Okay, so Medicare and caregiver services. So when we're looking at and thinking about what Medicare is going to cover, how Medicare policy is directed toward caregivers, it's important to clarify skilled caregiver services and unskilled or non-medical caregiver services. So a caregiver could provide some functions like companion services. That would be where they're offering, company. They are providing activities, and otherwise supervision. So again, if you are making group activities or you're just there to provide again companionship and overall supervision, that'd be companion services. Personal care services would be with assistance with personal care, potentially exercise, dressing, eating. Homemaker services, more of again the space, you're talking about housekeeping, assistance with shopping or otherwise transportation, getting them to and from certain appointments, for example. And then skilled care, where you are usually seeing this care done by a licensed medical professional. They provide therapies, medication management, and other skilled medical assistance to the beneficiary. Okay, so again, we have a background on how CMS views and identifies caregivers, some of the types of caregiver services via skilled and unskilled. And now we're going to talk about, again, Medicare basics, just touch on it quickly to talk about, again, Medicare, original Medicare, Medicare Advantage, under the overall Medicare umbrella. So again, I'm a visual person. I like to have a good graphic here to help me keep things straight. So again, there's the general Medicare. We have the umbrella, if you will, or the larger looming agency. We have two types or two ways that you can receive that health insurance, whether that's with original Medicare, that's Part A or hospital insurance, what we would normally think of as hospital insurance. Part B would be medical insurance, doctor services, outpatient services. You have Medigaps that are also associated with original Medicare, and then Part D, which is going to be prescription drug coverage. On the other side, you have Medicare Advantage, that is a substitute for original Medicare Parts A and B. And Medicare Advantage is when you have private companies that are contracting with Medicare, again, that overall agency, and they provide their plans and they contract with Medicare to get those plans approved to offer those types of services. Similar, again, a substitute service from original Medicare. So you would see with those plans your hospital and your medical and potentially your prescription drug coverage bundled all into those plans, and that's considered Part C. Again, it has those coverages all grouped together. Not always for Part D, or prescription drug coverage, but many of them do. Again, back to our Medicare overview, we're still talking about Part A and B. Medicare Part A is going to cover and include like inpatient hospital care, skilled nursing care, home health care, and always hospice care. It's going to be free if beneficiaries have worked 10 years or approximately 40 quarters, and this can be based on the beneficiary or the spouse's employment history. For Medicare Part B, again, that's going to be outpatient services, medical insurance, as we would think. So different preventative services, diagnostic tests, mental health services, and also home health care. As you see, it's on both sides. It can be in certain circumstances covered by Medicare Part A or Part B. And durable medical equipment, or DME. And as I mentioned earlier, Part B does have a premium that is, that amount does change each year at the cost of living adjustment or COLA time. For 2024, that premium, again, the general monthly premium based on total gross income is going to be $174.70. If people do have reported income that's more than, again, their general amount, you could see an additional fee called an IRMA, or an income related monthly adjustment. But again, the general amount is $174.70 per month. Okay, so more about the cost sharing for the beneficiary with Medicare Part A. So for Part A, hospital services in 2024, the beneficiary is paying a deductible and then a rate amount based on how many days they're in the hospital. And this is all based on a benefit period. So again, the deductible is going to be $1,632 for a hospital stay between 1 and 60 days, up to 60 days. So if there is an additional requirement to stay for longer, that would be days 61 through 90, the beneficiary would be responsible for $408 per day for a longer stay. There are also lifetime reserve days, 60 total lifetime reserve days for a beneficiary, and the dollar rate per day for that is $816, again, based on those lifetime reserve days. Once those days are exhausted, they do not come back. Again, that's if additional days are needed for an extended stay. And this is, okay, skilled nursing facility stays, then is the next one for 2024. So the important thing to remember for a skilled nursing facility stay is that to have those services paid for by Part A, Medicare Part A, you need to meet the 3 midnight rule, where the beneficiary has been admitted to the hospital inpatient for 3 midnights. So that's not counting the day of discharge, time in the emergency room, or any type of observation status. It would be, again, being admitted inpatient to the hospital for 3 midnights. Once you've met that criteria, the beneficiary has $0 requirement for the first 20 days for skilled nursing facility stays. And then after that, for days 21 through 100 of a benefit period, the cost is $204 per day. All right, so that's under Medicare Part A cost sharing. And then we have Medicare Part B cost sharing. So for Part B services in 2024, the beneficiary is responsible for an annual deductible, and that amount for this year is $240. After that, there's a 20% coinsurance, again, for most Part B services. And that is as long as your provider accepts assignment. So what's assignment? So assignment, when a doctor or provider accepts assignment, they work with Medicare, they have a contract, an agreement with Medicare, and essentially they accept the Medicare approved amount for your service as full payment. Again, they are in agreement that the Medicare approved amount is the full payment for whatever service you're trying to get. So you would have that service done, the claim would go through, Medicare would pick up their 80%, and then the beneficiary would see the final bill for the remaining 20%. If you have a non-participating doctor or provider, they accept Medicare, they work with Medicare, but they do not take assignment. They don't agree on that full payment amount. It means they can charge up to 15% more, 15% more than the Medicare approved amount. They can potentially ask the beneficiary to pay the full price up front and then seek reimbursement from Medicare afterward. Otherwise, the beneficiary would again be picking up that additional 15%. So Medicare would pay their percentage. The beneficiary would have that 20% coinsurance, but then they would also be responsible for that additional 15%. And that is considered excess charges. Again, for a non-participating provider, that additional amount that they can charge for their service. Or you have an opt-out provider, and an opt-out provider does not work with Medicare at all. They don't have any contract in place. So the potentially the full service dollar amount would be on would be the beneficiary's responsibility, and Medicare would not reimburse them. So you want to make sure that you know what the provider's relationship is with Medicare. All right, so we talked about Medicare A and B, some general cost sharing for, again, like skilled nursing facility care. Home health care is now what we're going to talk about as well, which again will be important for caregiver services. So Medicare and home health care. Home health care services can be, again, covered under Medicare Part A and B, as we saw earlier, depending on the circumstances. So that can include caregiver services like skilled nursing facility care, and this would be provided on a part-time or an intermittent basis. This could entail like wound care, pressure for sores or a surgical wound, different nutrition therapies or injections, and again, just monitoring a serious health or unstable health status for the patient or the beneficiary. Also, physical or occupational therapy, speech and language therapy, different medical supplies for use at home, and medical social services. So, this could be like different needs or risk assessments and care navigation as well. Um, the last thing here would be home health aid services, also provided on a part time basis. This would only be something that's included with home health care when it's being received in coordination with skilled nursing care or therapies. So again, it couldn't be approved on its own. Home health services, home health aid services on a part-time basis can potentially be approved when someone is also receiving and requiring skilled nursing care or therapies simultaneously. So this could be like help with walking, bathing, grooming, changing bed linens, and then feeding as well. So, Medicare can cover home health care services provided in the home when these criteria are met. So, again, some types of caregiver services when these criteria are met. The doctor certifies that the beneficiary is homebound. So, due to the condition of the beneficiary, it's recommended they stay in the home. It's difficult and or impossible for them to leave the home on their own. So without assistance from another person, wheelchair, walker, crutches, or other types of, transportation assistance. Um, there is a note that you can still be considered homebound even if you do from time to time leave your home due to medical, non-medical, and or religious reasons, or if you are eligible for adult daycare, you can still be considered homebound. Again, per your doctor, they would need to certify that. So again, as long as it's either very extremely difficult and or impossible for you to leave the home on your own if you would need assistance. Another criteria that would be required is that the patient is under care of a doctor. They have a healthcare provider assessing you face to face and ordering your care. They're making that plan, and services are provided by a Medicare certified home health agency. So again, we talked about part-time and intermittent. So generally, part-time or intermittent skilled care means that you may be able to get skilled nursing care and home health aid services of up to 8 hours a day combined for a maximum of 28 hours per week. So again, it's not ongoing full-time care, it's part-time and intermittent skilled care for these home health care services. All right, for home health care, for approved Medicare home health care with original Medicare, it's $0 for covered home health care services. After the beneficiary meets that Part B deductible, they can have a 20% coinsurance for the Medicare approved amount of medical equipment, durable medical equipment as well, if needed, again, in the home. So a home health agency should inform you as the beneficiary if Medicare won't pay for any items or services, and they must let you know if you would have to pay for them before they provide it to you. So again, they need to let you know before you just get a bill in the mail. And this is called the Advanced Beneficiary Notice, the ABN. So again, they would let you know if Medicare won't pay for something and if it would be on your responsibility. Okay, so again, talking about what Medicare does cover with home health care services and specifically thinking about caregiver services. What Medicare does not cover, again, long-term care, custodial care, 24-hour care at home, all things that are not covered, and personal care, again, when that is all that's needed. Some of those home health aid services, again, can be approved on a part-time basis as long as the skilled care is also being ordered and required. So not just personal care when that's all that the beneficiary would need. Medicare does not cover caregivers for their clients' activities of daily living or those ADLs in the home. So that could be meal delivery, cooking, dressing, cleaning, bathing, showering, anything like that. It would not be covered with Medicare, original Medicare. So that's a lot of things that are not covered. That's a lot of things that, again, caregivers, family caregivers, people assisting maybe their neighbors, um, would potentially need help with. And there were some studies done. This one, according to the National Alliance for Caregiving, the NAC, only 13% of caregivers said a healthcare professional has asked what they need to take care of themselves as caregivers, trying to also take care of someone else. Only 13%. Again, per that same National Alliance for Caregiving study and AARP, they did research that found that fewer than 3 in 10 caregivers, or roughly 29%, said that they have had general conversations with health professionals like a doctor or nurse or a social worker about their duties. So less than 29%. With the ratio of available caregivers to those needing care declining nationally, CMS, again, the Centers for Medicare and Medicaid Services, is striving to make policy changes to better support caregivers and provide more resources to, again, improve the caregiver experience. And we're going to talk about that. So, 2024 Medicare changes for caregivers. So, as of January 2024, new policies are in place to offer caregivers better support. This is through the Medicare Physician Fee Schedule, or the PFS. Again, the Medicare Physician Fee Schedule. It included a number of changes directed at improving services available to family caregivers and Medicare beneficiaries. So the big thing for, again, 2024 with this is, again, recognizing, describing, defining what caregivers are, and also really what they need. So providers can now get paid to train family caregivers. So this is a general Part B cost sharing, again, which we talked about earlier with the deductible and coinsurance. Those potentially apply. But again, now it is available for family caregivers to get this training directly from medical professionals. Medicare can pay clinicians for training services provided to caregivers who need assistance, and it can also include assistance with those activities of daily living. New payment codes, which we will show later in this presentation, for caregiver training services have been created with different timing allowances. So depending on the needs of the caregiver and the beneficiary, and both group and individual training options. Under Medicare Part B, payment can also be made to an expanded number of providers. So not just, specific doctors. This can go to nurse practitioners, therapists, certified midwives, and different settings, whether it's in a facility or a non-facility, as part of the treatment plan that's been, again, approved by the doctor. So payment can now be made for caregiver training services also when the patient is not present, which is, again, so important for caregivers that, again, need that training even when the beneficiary themselves is not always there. The other addition to this fee schedule and added for 2024 is that Medicare can now provide additional education for people with serious conditions. So policies allowing for medical professionals to provide caregiver training services more than once per year. Additional support can be provided for those with certain types of cancers, dementia, and HIV and AIDS. So for certain illnesses, additional help is available and can be provided. As I mentioned, these are those codes that, again, they show right there the service, but the participants, you could have multiple sets or one or more caregivers for a single patient. Again, different times that are allowable. So again, medical professionals can now bill using these codes and provide those services now to caregivers. Different trainings, additional time, help with, again, ADLs, those activities of daily living can all be included, training for parents, guardians, caregivers, mental health or physical health diagnoses, all of that good stuff. The last option there, 97552, can help with mobility, communication, swallowing, feeding, different safety practices, really important things that are essential for family caregivers or just caregivers, again, neighboring caregivers, to be able to provide that type of technical know-how and knowledge for the beneficiaries. All right, the last thing that we'll talk about with some of these changes with the physician fee schedule, is launching a new model, and it's called the GUIDE model, Guiding an Improved Dementia Experience. So this is a volunteer program, and it's striving to support beneficiaries with dementia as well as their unpaid caregivers. Participants in this model are providers. They're Medicare Part B enrolled providers and suppliers. So again, they are in contract with Medicare, and will establish dementia care programs, or they're calling them DCPs, that provide ongoing and coordinated care and support to people with dementia through this interdisciplinary team. So involving lots of different, again, providers to give a more person-centered care model for beneficiaries with dementia. So if a participant, or again, that provider can't meet the guide care delivery requirements, they also have the ability to contract with other Medicare providers to meet, again, the care delivery requirements. So again, meeting this more person-centered and coordinated care model that they're striving for. So it's designed to help reduce Medicare and Medicaid expenditures by helping people with dementia to remain in the home and reducing hospitalizations, ER visits, and long-term nursing care. So they are hoping to, again, have this model address and really improve dementia care and services in 5 different ways. One being defining a standardized approach to dementia care delivery for model participants. So, different quality standards, thinking about staffing considerations, how many people you have on staff to be able to handle the need in the community, and services for people with dementia, again, and their unpaid caregivers. So, again, a standardized approach to improve the care delivery model, providing alternative payment methods to model participants. So they're doing a monthly per beneficiary payment to support, again, this more collaborative care approach. They're addressing unpaid caregiver needs. So again, more support and training, more resources for caregivers. It attempts to alleviate that burden experienced by unpaid caregivers by requiring model participants to provide training and support services, including 24/7 access to a support line and connections to community-based providers. Respite services, important for caregivers. So Centers for Medicare and Medicaid Services is paying model participants for respite services, which are temporary services provided to a beneficiary in their home at an adult day center or a facility that can provide 24-hour care. And that is to give the caregiver, a needed break from providing those services on a regular basis. The last thing would be screening for health-related social needs. So looking past just the specific maybe medical care and thinking about the social needs for the beneficiary. So model participants would need to screen beneficiaries for psychosocial needs and health-related social needs, and helping them navigate that on a local community basis, and going through different organizations to help address those social needs as well. Okay, so again, with this guide model, services for folks living with dementia and their caregivers. So again, these 5 steps are kind of just what we talked about as well on that previous slide, where it's really focusing on person-centered care, comprehensive assessment and care plan. So you're getting assessed and you're having a doctor, and again, this coordinated and kind of interdisciplinary team helping develop your care plan that's going to be really tailored to you. And again, big for us, this caregiver support is a really big thing. So a relative or maybe an unpaid non-relative who helps you can get that education and support, direct communication with your medical professional or a care navigator when you need it. And again, those respite services you can get provided, potentially an annual cap, so caregivers can take a break when they need to. You won't feel, so burnt out or overwhelmed with the caregiving that you are providing. Um, Coordination and support. You can get community-based services like meals and transportation. Again, you are having that screening done to assess your other, social needs and having those needs met through local organizations. And then 24/7 access, again, those care navigators, being able to provide 24/7 assistance to your care team and essentially your caregiver as well. This is another kind of example about how more of a real life example. So, Mildred's an 86-year-old woman living alone with moderate dementia. She has regular appointments with her primary care doctor, dentist, optometrist. She gets her medications from a local pharmacist, and she has a caregiver, Anne, and that's her 35-year-old granddaughter. And she visits daily to help with housekeeping and personal care tasks. So again, some of those personal care assistance services, not that skilled care services that we mentioned earlier. And is a mom with a full-time job. So again, before this guide model was again launched as of 2024, Mildred was potentially experiencing worsening symptoms related to her dementia. Her primary care doctor wasn't equipped to treat her dementia. She needed help getting to appointments and taking medications. And Anne was burnt out as a caregiver. She has a full time job. She's a mom and she's going there every day to help with other tasks for Mildred. So Anne was burnt out and wanted to find Mildred a nursing home, but again, running into those high costs. So with this guide model that again is designed to provide that person-centered care to help people stay in their homes, Mildred learns about guide from her doctor and starts working with an interdisciplinary care team. Mildred's care navigator connects her to transportation services. Anne gets caregiver training to help with Mildred's symptoms and her own stress, and Mildred receives that guide respite services allowance, and that gives Anne a break when she needs it. All right, last thing about the guide model. I just think this is a great graphic. Again, it kind of shows you the left side being your more common dementia care experience, and then the right side after this launching, again, which is really focused on providing caregivers and unpaid caregivers all of the resources and training and education that they need to provide this better person-centered experience for the beneficiary that has dementia. So Margaret has been diagnosed with dementia. Her daughter Kathy is her caregiver. Margaret and Kathy are concerned about Margaret's future and being able to meet her evolving needs at home. So again, I won't read through the whole graphic because I know it's quite a bit of information, but you can see as well under this guide experience, this guide model, the experience is quite different. So it's again a comprehensive package of services to improve the quality of life, where along the way, again along the path of this guide model, Kathy as the caregiver is getting assistance. She's working with a team of people that kind of knows and understands Margaret's diagnosis and how they can be of assistance. And along the way, just having that support from that interdisciplinary team making a huge difference. Okay, so now talking about assistance that we can get for paying for healthcare services. So, Original Medicare does not offer reimbursement for family caregivers. It also doesn't provide payment for long term care services, again, like adult day services. That was one of the things that Medicare does not cover. So, thinking about options to help pay for out of pocket costs, one of the options would be looking at a Medigap. Medicaps are those lettered plans that again supplement or fill in the gaps of original Medicare. So a Medigap and a Medicare supplement plan, those are two phrases for the same thing. It's a private insurance company that administers Medicare supplement insurance, or again, like I said, a Medigap plan to help pay for Medicare Parts A and B, co-payments, co-insurance, and deductibles, some of that cost sharing mix. So for Medigaps, plans K and L do have an out-of-pocket limit. So once someone's costs do reach that limit, the plan would potentially pay 100% of Part B services, which could lower the amount that someone's paying for a caregiver. And this is just a chart that illustrates that. As you can see right in the middle, you have plans K and L, and there is an out-of-pocket limit on both of those. And there is a little, note at the bottom with next to the number 2 that plans K and L pay 100% of covered services for the rest of the calendar year once you meet the out-of-pocket yearly limit. So again, if you are paying for those caregiver services, having an out-of-pocket limit could definitely help, decrease your costs long term if you are, again, meeting that as you pay for your services. Excuse me. Sorry about that. So again, and with Medicaps, those are standardized plans. So letters A through N, they are um, going to be the same benefit structure, the same mix for like a G plan, if you will. It's going to be the same product for one company as it is for another. They have to offer the exact same coverage in each lettered plan. The only difference is that different companies can charge different rates for their product. So again, but it's going to be the same coverage for each in each letter. That's part of that standardization process. Another thing to consider with Medigaps is the birthday rule that was just instituted July of 2023, so last year. Beneficiaries have the opportunity to change their Medigap plan if it's deemed an equal or lesser value to their current plan. They can also switch carriers or companies if they're staying in the same lettered plan. So again, it does give an opportunity for someone to make a change to a Medigap that they currently have. You'd be able to do this every year during the 30 days following your birthday without being medically underwritten. For more information about the different products available, the Maryland Insurance Administration, the MIA, does have a booklet that they can send out to you. I think that booklet's about 100 pages by now, and they update the different premiums, the information at least every January and July. So you can call them to get the most recent booklet with the most pertinent information. All right, you can also look at Medicare Advantage plans, or again, Part C. We looked at that a few slides ago with that graphic that would have been on the right side. So Medicare Advantage plans, some are available that offer coverage for services like meal delivery, limited caregiver reimbursements, and rides to medical transportation. That can definitely help reduce costs and overall workload for family caregivers. Certain special needs plans or SNPs are also tailored to beneficiaries with like chronic illnesses or certain illnesses. You can contact a plan for more information about that coverage and those additional or extra benefits. So again, there are certain things that Medicare Advantage can provide because they are, again, it's insurance through private companies. So they have some of those supplemental benefits. Also Medicaid. So if Medicare does not cover, again, certain like long-term care or custodial care, 24-hour care, Medicaid can sometimes step in. And if someone's eligible for Medicaid and Medicare, Medicaid can potentially offer some coverage for those services. Individuals qualify for Medicaid if they have limited resources and income or potentially a disability. Medicaid is administered by the Department of Social Services, DSS, and they make those determinations. They may help with costs that Medicare does not cover. Just as a note, Medicaid is always the payer of last resort, and you can apply through your local Department of Social Services office. All right, other programs that can help reduce overall out-of-pocket cost for health services, healthcare, health insurance. The Medicare savings programs, and there are two that we'll talk about. The first is QMB, Qualified Medicare Beneficiary. That's a really special program. It has its own card, a gray and white paper card. It's also administered through DSS, or the Department of Social Services, and there are strict income and asset guidelines, but this does help pay for premiums for Part B. If someone does not have free or premium-free Part A, it can potentially pay the premium for Part A. Co-insurance, co-payments, deductibles associated with both original Medicare and Medicare Advantage. So a great program if clients can meet, again, that income max. The other program, the sister program, is SLMB, which is the Specified Low Income Medicare Beneficiary Program, SLMB. And that's also, again, administered through the Department of Social Services, has a slightly higher allowable income. But this plan, unlike QMB, it only pays for the Part B premium. That's the only thing that it covers. So it's not as specialized as that QMB program that pays for just all of the co-insurance, co-payments and deductibles associated with Medicare. All right, the other program that we'll talk about is the federal program. It is administered by Social Security, and it's also called Low Income Subsidy or LIS. Again, it's a federal program that helps with costs for Medicare Part D premiums, deductibles, and copays. You can go online to apply, it's ssa.gov. You can call Social Security. SHIP counselors can also help screen for extra help and help submit a like third party application, if you will, like a representative application. They can also do that. Um, Extra help also has an income and an asset limit, but again, it really does assist with care for, again, deductibles, copays, and premiums for Part D. All right, so we talked about some state programs, some federal programs, other ways to look at potentially cutting costs for as a caregiver and for caregiver services. So the last thing that we're going to talk about is well, Medicare fraud and making sure that you are aware of and considering things to be on the lookout for as you help read notices for the beneficiary as a caregiver, and what you can be, again, on the lookout for as you assist them in their daily living activities. So we know that beneficiaries and, like I said, caregivers are on the front line for fraud prevention. So to dig into fraud a bit and define that fraud being the intentional deception or misrepresentation, it's made knowingly and willingly to secure an unauthorized benefit from Medicare. So again, it's the key words there being that it's intentional, knowing, and willingly. Abuse would be practices that are, not good business practices, not ethical practices, or accepted medical practices. Again, that a provider is potentially engaging in. As a caregiver, again, when you were looking at and helping review paperwork for the beneficiary, you can potentially get access to their Medicare account. Again, you can review claims from there. Again, when you were reviewing the paper formats for Medicare summary notice, if you have original Medicare, if the beneficiary has original Medicare, or the explanation of benefits, the EOB, those potentially arrive quarterly. So again, reviewing those, making sure that you're following the 3 R's, are one being record, that you and the beneficiary are recording, each office visit, specialist visit, any kind of services that the beneficiary is getting. You're making note of the date, the time, the provider name, somewhat of the services that were provided, what the outcome was, information like that. And again, making special note of the date and who the beneficiary saw. So again, the R number 2 would be review, that you're again going through those notices. Maybe you're taking a look at that Medicare account for the beneficiary to review those claims and make sure that there are no discrepancies and that you don't have any questions or you don't feel like there are any errors. Following up with the provider, if you do see something that doesn't make sense to you or something that you have additional questions about, if your concerns are not being met or you feel like you're not really getting a straight answer or it's not resolved, definitely following the third R, which is report. You can report it to Medicare directly. You can also call SMP, Senior Medicare Patrol, which is with the SHIP office here with Baltimore County Department of Aging. Again, you can call the SHIP office for any other assistance with that. We can help review those reports and potentially escalate a claim as well if you feel like if things are still not clear and you have questions and you suspect there may be something fishy going on. All right, so thank you again so much for all of your time. These are some of the references of information for the presentation. Again, the 2024 Medicare Physician Fee Schedule Final Rule, looking at, again, different documents, the guide model, social needs FAQ, home healthcare services right on Medicare.gov, all of that good information. And again, if you do have further questions, we have the State Health Insurance Assistance Program number for Baltimore County right there, the SHIP number, and then also the Medicare number, and always visiting Medicare.gov for more specific questions about coverage, benefits, all of that good stuff. So thank you so much for all of your time and attention, and I hope you have a great day. Thank you, and you can call us again if any questions do come up. Our number is 410-887-2059, and have a great day.